Happy evening to you all who joined on this Saturday weekend, a special day, Valentine's Day, for an academic feast by Dr. M. Suresh Kumar and Dr. D. Srinivasan, well-renowned psychiatrists across the globe from India. First of all, I welcome all the delegates joined across India to this webinar, and I welcome the faculties today, the Honorable Chairperson Dr. D. Srinivasan, Senior Consultant Psychiatrist from KMCH Hospital and Research Center, Coimbatore, and the distinguished speaker, Dr. M. Suresh Kumar, Senior Consultant Psychiatrist, retired Professor of Psychiatry of Institute of Mental Health, Chennai. A brief introduction about Linux Laboratories Private Limited, the fastest pharma company, growing company in the CNS segment, and fastest growing among the top 100 pharma companies, now at 67th rank as per January ORG ranking. An organization currently clocking 400 plus crores in Indian pharma market in moving average target, and 12 months moving average data by IQVIA is 400 plus now, with awarded last 3 consecutive years the best place to work, Linux Laboratories. And Linux Laboratories started its humble journey 18 years back, and today spread across the length and breadth of the country, not only in India, also present in 15 plus countries across the globe. Linux has its own state-of-art 2 WHO GMP manufacturing units, and are proud to say we are the market leaders in l-carnosine brand. Our brand name is Ignicar, and pioneer in scientific initiatives in l-carnosine. Now it is time to introduce the chairperson. For him, there is no introduction required. He is actually a very big legend and giant in psychiatry. Across the world, people know him. A small introduction. The chairperson with us, Dr. D. Srinivasan, is a highly respected consultant psychiatrist with an illustrious career spanning over 4 decades. He completed his MBBS from MMC in 1979, followed by his DPM from the Institute of Mental Health and MD Psychiatry in same Madras Medical College. His early work as a senior research officer for Ministry of Welfare laid the foundation for his enduring commitment to mental health care. Since 1992, Professor Srinivasan has been a consultant psychiatrist at KMCH Hospital and Research Center, Coimbatore. He also serves as the medical director of the Kasturiba Gandhi De-Addiction Research and Rehabilitation Center, an NGO that has treated over 15,000 patients. Innovative methods to increase abstinence rates. The center also runs a suicide prevention hotline.
Okay, close
thousands of people. Yes, sir.
Okay.
Yeah, yes, sir. Sir, over to you, sir. We are interested to know about this topic today, the much awaited topic, adjunctive strategies in psychiatry and exploring the role of l-carnosine. I request Dr. Srinivasan, sir, to take over, sir, from here.
Thank you very much for that introduction. L-carnosine, right from the beginning. When the first brand came into the market, I was the one who jumped over it and started using it. I had a lot of practical experience. In fact, I have guided a lot of colleagues also on that. And it was surprising that Suresh was saying there are more neurologists using than the psychiatrists, but psychiatry, we have found a lot of users, and in and around the place where I'm working, I think psychiatrists lead the role in that. And I'm happy to be chairing this session where my close friend and teacher, Dr. Suresh Kumar, is speaking today. Like you said, our careers were almost together. MBBS, we studied at the same time. DPM, he was a year ahead, and MD, he was 2 years ahead. And when I did my MD, he was my teacher as well. And he is a much sought after speaker, professor, and even now his passion for teaching, learning on a continuous basis. Like, I am more a clinician, and I read patients and I get the results, and whether something works or not more intuitively, whereas Suresh Kumar is able to put the science behind it and why it works and why it doesn't work. And when he speaks, he makes even the complex topics very, very simple, but the amount of work he puts behind in preparation to make it look so simple is enormous. And his grasp is fantastic, though his original interest is drug abuse and related areas, and then he went into supervising in many countries, and he is an MPH His credentials are phenomenal, and if we have to really do justice to introduce him, it will take an hour to do that. Now I request Dr. Suresh Kumar, fondly known as Suresh, to take over and go ahead and explain why l-carnosine, though it's not a drug, it's more a adjunctive and it's more a food supplement. That's the grade in which it comes. But it has gained a lot of importance recently, and more than 100 brands of l-carnosine may be available in the market or even more. That shows how popular and how much demand it is in, and every company wants to jump into that. That's the demand for l-carnosine is there, and Dr. Suresh will explain more on that.
Uh, Thank you so much, Dr. Srinivasan. Indeed, it's a privilege for me to be part of this webinar initiated by Linux, more so because my very close friend, a person whom I admire personally, is a chair for this webinar. So I'm indeed fortunate that Srini is around. Thank you, Srini, for very kind words. I don't know whether I really deserve such words, but I think coming from a friend, I do respect that. Today, I'll be talking about adjunctive strategies in psychiatry, particularly exploring the role of l-carnosine. Can find out what's okay. The outline for today's presentation is, I will first begin and asking this question: what are adjunctive strategies and why do we need it? And I will talk about l-carnosine as a molecule, how it is relevant in neuropsychiatry. Particularly, I'll talk a lot about the mechanism of action, which will actually help us to understand this molecule and its relevance in neuropsychiatry. And I'll also go and look for evidence in very specific neuropsychiatric disorders that we already know of. And then I'll talk a little bit about clinical applications, dose, and clinical use before I give you the final takeaways. So first question to all of you: what is an adjunct? When we talk about an adjunct, we are talking about any therapeutic intervention which is added to the primary treatment. So there is always a primary treatment for a given disorder, and I think you add another drug, and that's an adjunct, and it is usually done to increase, to enhance the efficacy of the original drug. Or sometimes even with treatment, adequate and optimal treatment, residual symptoms linger. So this is given to address that residual symptoms. At times, the primary drug, if you increase the dose, it may not be tolerable by the lived experience of the patient. And I think in that times, this particular adjunct will improve tolerability by reducing the dose a little bit. More importantly, we do know there are so many pathophysiological mechanisms that are responsible for the genesis of the psychiatric disorder. And I think often we don't target those pathophysiological mechanisms with the original drug. And this adjunct may help us to target. So if you conceive psychiatric disorders as disorders of brain network combined with pathology at a cellular level, that's the best understanding we have about neuropsychiatric disorders at this point in time. So if you think about it and conceptualize it as a disorder of brain network, as well as a disturbance in the pathology at a cellular level, you look at the medication that we have that is largely used in psychiatry, the psychotropics, they're primarily targeting neurotransmitters. This is a way forward for a long period of time. So that means there are a lot of things which are unaddressed. The most important thing that are unaddressed are the pathophysiological mechanisms that contribute to the genesis of the disorder, particularly the oxidative stress, the inflammatory pathways, the mitochondrial dysfunction, the neuroprogression that occurs in many chronic enduring disorders. All these things are not addressed by the primary drug often. So I think when we talk about adjunctive therapies, we have different types of adjunctive strategies. It could be pharmacological, Typical example, one would say, is adding thyroxine to a treatment-resistant depressive individual. When he fails with several antidepressants, you add an adjunct like thyroxine. It's not a primary drug, it's an adjunctant. That's a pharmacological adjunct. Or it could be a nutraceutical or a biological adjunct, or it could be a psychological adjunct, adding CBT in addition to providing antidepressants. CBT as not a primary treatment, as an adjunct sometimes. Or neuromodulation, like repetitive, like RTMS or TDCS being offered as an adjunct to medication. Or lifestyle modifications, which often be prescribed to individuals with neuropsychiatric disorders. They also can come as adjunct strategies. So there are several adjunct strategies we think about. I think we are focusing here on the nutraceutical targets. How can we make a nutraceutical an adjunct, and what is the purpose of it? If we talk about a pathophysiological mechanism like oxidative stress, typical examples are you provide antioxidants like l-carnosine, or you talk about vitamin E or NAC. Any of these things could come as antioxidant medications that could be specifically targeting the oxidative stress. Or you talk about inflammatory pathways, you're talking about omega-3 fatty acids as a way to address that. Or if you know there is a mitochondrial dysfunction, which is one of the core pathophysiological mechanisms contributing to the pathology, then you can think about coenzyme Q10 or L-carnosine. Many psychiatric disorders are due to excessive glutamagic transmission, and I think that's a very toxic thing to the brain. Drugs like N-acetylcysteine may be addressing that. So you have different nutraceutical targets we are familiar with, and they are addressing different pathophysiological mechanisms. Now, after having understood what is an adjunctive therapy and why we need it in neuropsychiatry, let's look at the molecule l-carnosine. L-carnosine is part of the histidine containing components, and I think this is very important. If you talk about L-carnosine, it is beta-alanine N-histidine. This is a naturally occurring dipeptide. The two peptides within this L-carnosine is beta-alanine and L-histidine. At this point in time, I want to make it clear to the audience. You may be reading the literature. When you read the literature, often only carnosine is mentioned. So people ask, is there a difference between carnosine and l-carnosine? L-carnosine is the one which is available in the tissues. That's what's available even synthetically and then as a supplement. So whenever you talk about carnosine, you're indirectly talking about L-stereoisomer of carnosine only. So L-carnosine, we can pretty much say when you're reading about carnosine, you're talking about L-carnosine. So I just want to bring the clarity to all of you. So it's a naturally occurring dipeptide which contains both beta-alanine and L-histidine. So obviously L-carnosine, we all know, is found, 90% of L-carnosine is found in the skeletal muscles, but also it's found in the heart muscles as well as in the brain. The brain has a very rich concentration of L-carnosine. L-carnosine in the brain, in the muscles and in the heart decline over age. And also it declines in chronic illnesses. And also when neurodegeneration sets in, this is also declining. So there are many instances in which L-carnosine is declining, and we should understand that. So it is synthesized normally by carnosine synthase, which combines the beta-alanine, L-histidine, which is an amino acid itself. And these two things are combined by this and synthesized by carnosine synthase. So most important is to understand this is degraded by a serum enzyme called carnosinase. This carnosinase has a very close gene polymorphism. And I think particularly the CNDP1 is the most important gene that is responsible. And I think that degrades the L-carnosine. This is vitally important. We'll talk about it when it comes to the, degradation of this particular molecule, why it is clinically relevant. At this point in time, I just want to mention that this is an enzyme which is present, which degrades the L-carnosine into beta-alanine, L-histidine. Okay, let's move to what this particular thing can do, biologically speaking. As I said, L-carnosine is present in the muscles, heart, and the brain. So it's got many functions. The most important biological function of carnosine is the antioxidant activity combined with the anti-glycation property. And I think another important one is also responsible for pH regulation within the cells. And it is regulating the energy metabolism, be it in the muscles, be it in the heart, be it in the brain. It is responsible for the regulation of energy metabolism, particularly through glycolysis and mitochondrial function. It also has immunomodulating properties, and it's got an inhibition property towards AGE creation. The advanced glycation end products are quite toxic, and I think that happens in many disorders, including in diabetes mellitus. And so the AGE creation is inhibited by carnosine. And it offers protection against many things like ROS, RNS, and advanced lipid oxidation end products. So all these things are very important biologically speaking. Carnosine also has a metal chelating property, particularly for zinc, copper, and iron, and also it has a calcium ion regulator. So it also has a suppression of tumor angiogenesis and also mTOR inhibition. Interesting to know that this is also going to protect against carbonylation and amyloid-induced toxicity. One of the reasons why we'll be considering it, like cognitive decline and dementia. So interestingly, it's also useful as a prevention of tumor cell adhesion, migration, invasion, and proliferation. It increases the tumor cell senescence. On the other hand, it rejuvenates the senescent cells and protects against the brain damage in stressful conditions. So you have variety of biological properties to this carnosine. But I want to ask this question, why this is so much biologically important, how is it relevant for us in the brain for brain-related disorders? Let me simplify and say, both beta-alanine and L-histidine is available in the blood, and they can cross the blood-brain barrier. And then within the brain, there can be a de novo synthesis. Most of the carnosine in the brain is through de novo synthesis. Some part of the carnosine can also go through blood-brain barrier and reach the brain as it is. So basically, the synthesis happens in the oligodendrocyte and the glial cells, particularly in the olfactory neurons. So both carnosine and homocarnosine, they act on the neurons as well as on the astrocytes. It's got an action on the astrocyte by facilitating lactate export. So in other words, it actually is able to protect the neuron. So the most important property of l-carnosine is neuroprotection. Let's examine in detail how well it can offer the neuroprotection. That's one of the reasons why we must be considering l-carnosine in neuropsychiatric segment. How does the neuroprotection happens through l-carnosine? First and foremost, by not allowing lactate to accumulate in the cells, I think the metabolic support for the neurons is achieved. Second, there is a pH buffering that is taking place in cells, particularly cells with a very high metabolic flux. Thirdly, it is able to regulate anti-inflammatory processes. And also, the advanced glycation end products are very toxic, and there is an anti-AGS activity by L-carnosine. Beta-alanine is also able to induce a tonic inhibition of the GABA receptor. So also, L-carnosine is able to do this metal chelation, particularly for zinc and copper, which can lead to neurotoxicity. You know, there is a hypothesis in which zinc neurotoxicity can lead to vascular dementia. That's one of the pathways to develop vascular dementia. There is also this reduction in carbonylation related cytotoxicity. So there is also this oxidative stress reduction through reactive oxygen and nitrogen species related toxicity. There is also this attenuation of NMDA-induced neurotoxicity, and also it actually works against the beta-amyloid-induced toxicity. And there is an activation of the astrocyte, which results in BDNF angioproduction. So L-histidine modulates histamine. That's a precursor to histamine. And the histamine also affects the actions of serotonin, norepinephrine, dopamine. So there's a lot of ways in which the neuroprotection of L-carnosine is driven. So let me go one by one in terms of mechanism of action for us to have some clarity about how l-carnosine acts in the brain. This is, I'm splitting it for a better understanding. First, let's talk about the antioxidant effects of L-carnosine. I want all of you to understand, being an antioxidant, it scavenges the reactive oxygen species and the reactive nitrogen species. That's exactly what happens with this. And I think L-carnosine can neutralize reactive oxygen species, particularly superoxide, hydroxyl radicals, and peroxyl radicals. All these things are handled very well. So the oxidative stress is handled by L-carnosine. And more importantly, it has an additional anti-glycation effects. Glycation is a chemical reaction in which sugars are binding to proteins or lipids or DNA or nucleic acids. So if a sugar binds with protein, lipid or DNA, it results in a skiff base. This is the reversible state. The skiff base is the reversible state. That leads to Amadani products. Typical example is in diabetes. In diabetes, you have this, advanced glycation end products. I think before that, there is an Amadani product. There is a glycated hemoglobin. So the sugar binds to hemoglobin. The more the sugar is, more hemoglobin is glycated. That's what you test once in 3 months to understand your glycated hemoglobin. But thankfully, at that Amadani product level, this is reversible. Still, the process is reversible. But then if you don't do anything about it, it's going to advance to advanced glycation end products. That's going to be toxic to the brain. Often it is irreversible. The AGS is toxic because it stiffens the proteins in the brain. It impacts the enzyme function. It cross-links the proteins. It activates the inflammatory processes. It increases the oxidative stress. So, anti-advanced glycation end products is a toxic thing, and this has got an anti-glycation effect. Also, it has got a lipid peroxidation effects. What is lipid peroxidation? It simply means oxidative damage to the lipids, particularly to the PUFAs in the cell membranes. Brain is full of PUFAs, and I think by the oxidative damage to the lipids, you have harmful products coming out of it. Typically MDA, melandialdehyde, or 4-HNE, which is 4-hydroxy-nonenal. These can damage potentially the proteins and the DNA, disrupt the membrane fluidity, and impair ion channels and receptors and trigger the apoptosis. So, if you look at it together, I'm going to combine all these things together and then say there is a vicious cycle that forms in the brain by the 3 mechanisms I talked about. We talk about glycation. Glycation can lead to increased oxidative stress. And increased oxidative stress can lead to lipid peroxidation. And lipid peroxidation by itself produces so many reactive aldehydes I talked about. And these can induce more glycation. So there is a vicious cycle, glycation leading to lipid peroxidation again going back to glycation. In the process, I think this cycle is quite toxic within the brain. What L-carnosine does is to break the cycle at different points. That's the most important function of L-carnosine. So why is it relevant? Because the brain is very lipid rich. Brain is an organ which is very lipid rich. Also, brain is the one which consumes high oxygen. It's a highly oxygen consuming organ. It has a very limited antioxidant reserve. So given this, L-carnosine is a good neuroprotective agent because it's suited. It works both in aqueous as well as lipid interfaces. It acts without suppressing the physiological ROAs completely. And it's also preserving the normal signaling. It does not disrupt the normal signaling. That is why we think L-carnosine as an antioxidant working through this oxidative stress, anti-glycation and lipid peroxidation can actually be a neuroprotective agent. Second, how does this antioxidant, anti-glycation, lipid peroxidation effects are clinically relevant? These things are relevant for many neuropsychiatric disorders across board: schizophrenia, depression, Alzheimer's disease, Parkinson's disease, autism spectrum disorder. In all this, the vicious cycle that I described is happening. So L-carnosine can be a useful tool in these situations. Now, after finishing with this, let's move on to the second mechanism. The second mechanism is the neuroprotection through its anti-excitotoxic effects. The excitotoxic effect in the brain happens mainly because of glutamate. Glutamate is the most abundant neurotransmitter present in the brain, and I think glutamate mediates toxicity in several neuropsychiatric conditions. And I think NMDA receptor activity is responsible for that. So this particular molecule is able to modulate the NMDA receptor activity as well as reduce the glutamate mediated toxicity. And also it is able to stabilize the intracellular calcium. So what does these actions useful for? The relevance of these actions are directly transferred to epilepsy, many neurological conditions like epilepsy, because it's able to stabilize the calcium, stabilizes the intracellular calcium, is very important in epilepsy. It's also very important because of the glutamate toxicity, stroke-related cognitive impairment, and neurodegeneration. In these conditions, it becomes highly relevant. This excitotoxic effect is reduced by l-carnosine, and that's why it's important for these conditions. The third mechanism of action of l-carnosine is anti-inflammatory. L-carnosine is able to downregulate many pro-inflammatory cytokines, typically tumor necrosis fiber alpha, IL-6, IL-1 beta, all these things we can routinely do in our clinical settings. You can see it's down-regulating all these pro-inflammatory cytokines. It is also modulating the microglial activation. So these two things are very important for the inflammatory process, and this serves as an anti-inflammatory agent. What is the relevance of the anti-inflammatory action on the brain? So, some subset of depressive disorder and schizophrenia is explained by inflammatory pathology. There's so many published work relating to the relevance of inflammation in depression and schizophrenia and bipolar disorder and PTSD. So in all these individuals where inflammation could be playing a role in these disorders, the drug could be relevant. Again, this particular drug has an action on the mitochondria, and the mitochondrial support is through improving the ATP protection, protecting the mitochondrial membranes, reducing the oxidative mitochondrial damage. We know mitochondria, the energy store of the body, is so relevant for many disorders like mood disorder, chronic fatigue syndrome, and most importantly, the neurodevelopmental disorders, which is a huge challenge for clinicians. In these conditions, I think l-carnosine has a role because of the direct effect on the mitochondria. And as I said earlier, this also has a metal chelating property. It chelates the copper, zinc, and iron. These are the metals. They can also produce neurotoxicity. It reduces the metal-induced neurotoxicity of the brain. So that this particular action becomes very relevant in many conditions, notably in vascular dementia, in which zinc-induced neurotoxicity is very relevant. Also in Parkinson's, Alzheimer's, and of course, Wilson-like neurotoxicity models in which copper metabolism is involved. So in all these conditions, again, this could have a role. Finally, this as l-carnosine as a molecule is also able to have an indirect effect on many other transmitters we're already familiar with. All the time, our psychotropic drugs are working only through these molecules. At least 3 of the molecules, put over there neurotransmitters. Most of the psychotropic drugs either work on dopamine, GABA, or serotonin. Unfortunately, there are very few working on the glutamate. So, but then this particular molecule can have indirect effect on these neurotransmitters. So, l-carnosine can be linked to reward because of its action on dopamine, cognition because of glutamate and GABA, and also the emotional regulation through serotonergic pathways. So I have summarized to you, and then you can say, so what does l-carnosine look like? L-carnosine to me looks like a multi-targeted neuroprotection. You're not talking about a single target and protecting the brain. You're talking about a multi-target neuroprotection. I would consider this molecule as a neurobiological buffer. This is the neurobiological buffer. That's the right kind of a word. So if you think oxidative stress combining with the neuroinflammation and the mitochondrial dysfunction leads to synaptic dysfunction and network instability, you are connecting to the very vital pathophysiological mechanisms of neuropsychiatric disorders. The combination of brain network disturbance combining with cellular pathological disturbances. And these are the ones which result in the so-called cognitive, emotional, and behavioral symptoms of very many neuropsychiatric disorders across board. So transdiagnostically, we look at and say this particular drug can be very usefully thought of as an adjunct, as a neurobiological buffer, as a multi-target neuroprotection. That is where this molecule is very important. Now I'm going to move, after learning so much about the mechanism by which it becomes relevant for people practicing in neuropsychiatry, we'll move and say, where is evidence for this particular molecule currently? Among all the neuropsychiatric condition, autism spectrum disorder has the strongest clinical evidence for l-carnosine. Thankfully, this is one of the conditions which is extremely challenging. Ask people who provide care to those people, who take care of people with the lived experience of autism spectrum disorders. That's a huge challenge. We don't understand the burden of the caregivers. And I think it's a huge problem, and we don't have anything to deal with them. And there is anything which is not modifying anything. So as an adjunct therapy, this could be playing a vital role. Here are the evidences that we have at this point in time. In children with lived experience of ASD, if you compare them with people who are healthy, age-matched control, l-carnosine as well as its precursor levels are reduced in the urine. The plasma levels of both beta-alanine and histidine, which are the precursors for l-carnosine, are found to be higher. L-carnosine levels are lower in the plasma. These are the findings that's been found in the literature. If you look at why is that there is a high beta-alanine, patients with lived experience of ASD have higher beta-alanine, which is mostly because of a gut reaction between ammonia that is produced in the gut and the propionic acid. A combination of ammonia with propionic acid results in beta-alanine. That's why its levels increase in the plasma. This beta-alanine, when it crosses the blood-brain barrier easily, beta-alanine itself in the brain blocks the receptor sites for GABA, which leads to GABA overprotection. So this is one of the pathophysiological things that happen in autism spectrum disorder. So in terms of evidence, I want to first point out a very important study done by Chess et al. And this particular study, I would think, is a pioneering study, even though it was done in 2002. And I think this is the first study that looked at systematically. It looked at only 31 children with ASD, and they provided 8 weeks of l-carnosine supplementation. The dose was 800 milligram per day. And the authors observed decreased autism severity scores compared to placebo, because it was a placebo-controlled trial. And compared to placebo, this particular drug reduced autism severity score. Particularly, they noted differences in behavior. Often it is eccentric and erratic. And socialization, which is a huge problem with people with autism spectrum disorder, and communication scores. So these three relevant issues, people found improvement. Improvements are also noted in the receptive language and also impression of change. Impression of change is something that is reported by the parents. Parents come and say that we do believe there is a change that is occurring in my son or my girl when I started giving this l-carnosine. So 8 weeks of 800 milligram has actually resulted in decrease in the autism scores in many areas. So again, very, very recently in 2018, 2 RCTs have been done. One RCT looked at 43 children, 8 weeks, but remember the dose here is 500 milligram daily. They did not demonstrate any change in the autism severity, even though they noticed improvement in the sleep disturbance, but they did not actually record severity of autism score difference. This could be very relevant to look at the dose that they provided, which is 500 milligram, compared to the earlier study in 2002, which was 800 milligram. So there was a repeat RCT again in 2018. And this one, the RCT was done in 70 children, 10 weeks of 800 milligram, along with risperidone, because it's an adjunctive therapy. And people noticed that there was a good reduction in hyperactivity. And children complied with treatment, both physical medication treatment as well as psychological therapies. I was talking to my good friend Srinivasan. He was telling in his experience, when he provides l-carnosine to children with lived experience of autism spectrum disorder, the predominant thing that he saw was that they're able to engage with non-pharmacological interventions better. And I think that is a very important thing that you should notice. So the improvement need not be necessarily seen directly, but I think there are many ways in which you can look at the improvement. So what do randomized controlled trials show so far? They show improvement in receptive language. They show some improvement in social behavior, which is one of the hallmarks of this disorder. And also, given as an adjunct to risperidone, it deals with the hyperactivity in these individuals. Because you can't keep on increasing the dose of risperidone, parents will get very worked up and side effects develop in the children. I think an adjunct like this would be able to help to reduce the hyperactivity. Please remember, the dose that works with the children is 800 milligram per day. If you're going to go on a less dose, you can't complain about the medication. I think you're not providing optimal dose to the person. Then look at schizophrenia, another baffling disorder that we deal with on a daily basis. This is remain a clinical challenge to all of us. And I think it'll continue to be so, I guess, because we've not made any significant breakthroughs. If you provide adjunctive carnosine, it primarily look at two things which are not addressed by current antipsychotic medication. The antipsychotic medication don't do much about negative symptoms. Even though every single drug is introduced by saying that it will address the negative symptoms, clinicians will vouch and say no antipsychotic that is currently available is actually doing anything about negative symptoms. So are the cognitive challenges. Cognitive challenges in schizophrenia is very important because if you say what is the one which predicts the outcome of people with lived experience of schizophrenia, it is not the positive symptoms. It is not the affective symptoms. It is not the negative symptoms. It is a cognitive impairment that predicts outcome. Whether somebody will go to school back, whether somebody will go to household work back, whether somebody will return to office work if he has a lived experience of schizophrenia, that's entirely decided by how much of a cognitive impairment is done by this baffling disorder. So it's very important for us to address the cognitive impairment in people with the lived experience of schizophrenia, given that we have no way to address it at this point in time. In addition to that, this particular l-carnosine can also reduce oxidative stress markers. If you consider schizophrenia, there are many ways of understanding schizophrenia. One of the ways of understanding is schizophrenia a redox imbalance combined with a glutamatergic dysfunction? If you think like this, you can think about l-carnosine as a redox modulator and so helpful for addressing the cognitive functions. So what is the evidence that is currently available? The evidence that is currently available, I'm going to talk about two RCTs. One RCT included 63 people. The other one included 75. Both had middle-aged patients, similar population almost. Chronic schizophrenia was a diagnosis. They were on stable antipsychotic medication, and the dose that was employed was about 2 grams per day. 2 grams per day. And the first trial, lasting about 8 weeks duration, reported improvements in the total score, in the negative symptom subscore for schizophrenia. If you do something like a PANS, and I think it calculates both positive and negative symptoms. I think Srini was the one who probably started doing that first way back in the 1980s. And I think still it's relevant for us, this particular scale. We have not forgotten this guy. I think the total score as well as the sub-score of negative symptoms are reduced in this first trial done by Gajar. The second one, led by an Indian author, Changappa, from US, in the second trial, for 3 months, no effect was found. But they demonstrated improvement in several cognitive domains. Even though they could demonstrate improvement in the negative symptoms, they did demonstrate improvement in the cognitive domains in several ways. Right. So, in our own backyard, at SCARF, at Chennai, led by Hema Tharoor and her colleagues, there is a randomized double-blind placebo-controlled study, which was published in 2023. Here, they looked at 100 people, randomly divided them into 2 groups, 50 each of people who were receiving l-carnosine, 800 milligram, and placebo, and then allowed them to go through weeks, and then they studied it. At the end of the study, they found there was no difference in the negative symptoms, but they did demonstrate the attention scores was statistically significant compared to the people who received the placebo. So they concluded this particular drug may be very useful in addressing the cognitive impairment in people with lived experience of schizophrenia. That's a study from India in our own backyard. Okay, so after knowing about ASD and schizophrenia, let's move on to one of the common psychiatric disorders that we come across on an everyday basis, namely depression. In depression, I want to emphasize two things. One, the meta-analysis of l-carnosine and their histidine-containing components. We call it as HCD. I think histidine-containing compounds are done as in the meta-analysis. L-carnosine showed improvement in depressive scores as well as in the improved quality of life. Not only they demonstrated there was a reduction in the depressive scores, but also in the improvement of the quality of life, which is a very important factor with people with lived experience of depression. Interesting to note, people are now looking at biomarker panels. The biomarker panel for depression is going to be available very soon. That really helps us, because one of the clinical challenges people face is when a first time a person is presenting with depressive episode, you don't know whether you are dealing with a major depressive disorder or you're dealing with a bipolar depression. It's only over the course of time you revise your diagnosis, and the treatment matters a lot between the two. How do you manage it between major depressive disorder and bipolar depression? So I think to reliably distinguish between the two, we require metabolic biomarkers. And in the metabolic biomarkers that are available at this point in time, 6 urinary metabolites. One of the thing is beta-alanine. So I think there is also l-carnosine may be relevant. That's one of the reasons why they picked up beta-alanine as one of the biological biomarkers in this panel. So if you look at one of the most complex disorders to deal with, for which the whole world is struggling, particularly when the population is aging, more and more people are presenting with lived experience of Alzheimer's disease, and how do we manage it? Given that there are only now attempts being made to make disease-modifying treatments, we need to look at and say, in our own settings, how do we manage people with Alzheimer's disease, apart from donepezil and memantidine and what else we can give? So levels of L-carnosine, as well as rate-limiting precursor L-histidine, are altered in Alzheimer's disease. These could actually serve potentially as biomarkers for disease progression, even though more evidence is required at this point in time. I believe in the future research, some of this will come as a biological biomarkers for us, and we can use it to track the disease progression. Interestingly, I talked, I think earlier also about the zinc-induced neurotoxicity and its relevance to the genesis of vascular dementia. So if you're suspecting in a person with vascular dementia, probably potential to develop vascular dementia, people with the long duration of hypertension, for example, and these are the people who are known to develop vascular dementia later on, maybe we should probably look at preventive strategies. And I think one of the preventive strategies could be l-carnosine. So I think this particular drug has been extensively studied when it comes to cognitive decline. This is where most of the work has been done with regard to l-carnosine. So if you look at the l-carnosine, there is one RCT which examined the effects of pure L-carnosine. I say the pure L-carnosine, some of them looked at only, beta-histidine, beta-alanine, L-histidine, and the combination carnosine, or sometimes anserin, all this has been tried. So this is one RCT just looked at only L-carnosine. The L-carnosine looked at specific population of individuals who were diagnosed as Gulf War illness. The people who participated in the Gulf War, and then they presented with illness when they went back. The typical symptoms included cognitive dysfunction, fatigue, and somatic pain, which is very, very widespread. And people thought we should treat them with L-carnosine supplementation, 500, 1,000, and 5,500 milligram of L-carnosine, increasing at every month interval. They demonstrated the executive function improved in these people. The Gulf War illness veterans mostly presented with the typical symptoms of cognitive dysfunction, particularly the executive function, that improved with l-carnosine. Also, interestingly, the diarrhea, which is closely associated with the irritable bowel syndrome, which many of them had, also improved with this medication. So, in matters concerning cognitive decline, most work has been done with co-supplementation with anserin. One of the reasons why we want anserin to be given, L-carnosine, I will talk about it. L-carnosine is easily degraded by the enzyme that we talked about, and the variability is there between individuals, how people will degrade depending on the polymorphism they possess, gene polymorphism they possess. So if we want to make sure that the molecules which is going to be neuroprotective is going to be available for longer periods of time and it remains stable, sometimes anserin comes as a good choice. Anserin is not easily degraded by the enzyme that you're talking about. So people usually mix these two things together in 2:1 or 3:1 ratio. And when you do that, particularly in cognitive decline, where you require a sustained effect on the brain is required, consistent findings have reported RCTs using co-supplementation of anserin with l-carnosine in 2.1 or 3.1 ratios. People have demonstrated cognitive improvements, or they have noticed preservation of certain cognitive domains over a period of time. So in 51 individuals with early stages of cognitive impairment, they have shown some arrest or improvement. In 68 carriers of the highly risky ApoE4 allele genotype, but these are the people who carry this genotype are much more at risk to develop Alzheimer's disease. And I think 68 carriers were identified and provided, and that actually made them to stay, and it preserved the certain cognitive functions in them. And this combination, co-supplementation of l-carnosine and anserin, also when they're given in older people, these are older people who didn't have much problem. They were healthy adults, but they were worried that they will be going through cognitive disability over a period of time. When they gave, it actually improved their verbal episodic memory. It altered their resting state network connectivity. So obviously, this could function as a cognitive enhancer in some of the people, particularly older people. So there is also this study which is very interesting, came back in last year, 2025. And this is a study that looked at younger population. Because these younger populations also sometimes, they say, we don't have any susceptibility, we don't have any pre-existing conditions, but still we want to have a higher cognitive function. And young individuals are looking for a higher level cognitive performance. They don't want any medication to improve their cognition. They want supplements. That's okay with them. So l-carnosine supplementation has selectively improved high-level cognitive performance in these younger individuals who are part of the study. So obviously, this has got a relevance in improving or preserving some of the cognitive domains. Now, what's the evidence of l-carnosine in people with attention deficit hyperactivity disorder, another neurodevelopmental disorder, which is highly challenging? There is only one ACT I could call out. This one RCT examined l-carnosine supplementation, which were 800 milligram per day, the same dose like autism, for about 8 weeks as an adjunct therapy in previously drug-naive children with ADHD. In this case, they found only modest but not significant improvements in the clinical symptoms. If at all any improvement was there, it was only in the inattention subscale, noted by the parents, not by the teachers. Teachers did not notice any improvement in the attention, but the parents did, because the scales of the parents are different from scales for the parents and teachers, and the parent rating scales denoted that there is this improvement in the inattention subscale. Okay, so what about literacy skills? This is something people will be wondering. Does it work with people with, for example, lived experience of dyslexia, or would it do anything with literacy-related skills? So an RCT was done in Finland. It investigated the effects of a supplement containing l-carnosine, 400 milligram daily for about 90 days in combination with omega-3 fatty acid they give. They did not find any outcomes which are like supportive, both in reading or spelling or language skills or arithmetical skills or attention. So at the moment, there is no clear evidence for us to embark on the journey of using it in people with reading skills, development problems or spelling problems or other arithmetical skills. What about the role in anxiety and stress? I was able to get a study by Japanese study. It looked at 87 healthy office workers. They took a supplement drink containing l-carnosine because they were healthy. They took about 200 milligram per day. And they also went through a computerized cognitive behavior therapy program. And these are people working in an office in Japan, and which is a very stressful work environment. And all of these people who took this medication and this supplement, they reported less tension. Self-reported tension was less, and self-reported anxiety was less compared to placebo. What about people with lived experience of OCD? This one thing that we have found out, 1 month of l-carnosine supplementation as an adjunct therapy led to reduced total scores as well as obsession and compulsion subscores in a study in Arab Satak study in 2017. And before drawing any conclusion on OCD and all that, I think we really require large scale studies. And I think look at whether, how the mechanism what Ladul is about glutamagic activity. We all know that. I think the glutamagic mechanisms are the ones which are implicated in OCD a lot. I think perhaps this is one thing that is plausible, but I think we require a larger study to conclude. Another interesting paper I found, one that relates to dissociative identity disorder. A combination of zinc with l-carnosine was found to be useful in a case study of dissociative identity disorder. And also, I think we know Gulf War syndrome patients also responded, sometimes, fatigue. There's really no greater evidence for complete reduction. So you can't actually go ahead and talk about it with confidence. So there are many neurological disorders. I'm going to omit all those neurological disorders because that's not under my purview. And I think, but there's so much of utility of this particular molecule in many neurological disorders because it addresses the brain injury directly. So whether it's brain ischemia or stroke or trauma to the head, brain, or Parkinson's disease or epilepsy, multiple sclerosis, and my friend Srinivasan added to the list acute autoimmune encephalitis. In all this could play a role, particularly, l-carnosine can play a role, if not directly as an adjunct. As an adjunct, this all could be used in these conditions. So if you look at a summary slide and say, what is the clinical phenotype for which l-carnosine may be very relevant? So the most important one, the vote will go for a neurodevelopmental disorder like autism spectrum disorder. Then we also know that people who exhibit cognitive slowing, be in older people, are wanting to enhance even in younger population, or in people like lived experience of schizophrenia presenting with cognitive impairment, I think l-carnosine can play a role. Even though our study did not reflect, our Chennai study did not reflect improvement in negative symptoms, perhaps the dose, the authors alluded that 800 dose may not be sufficient for negative symptoms. Perhaps one should try with about 2 grams. And so there will probably, you can have some better results with the negative symptoms. So fatigue here and there, of course, it is not an adjunct in the acute psychosis. Only we deal with the primary medication. What is the dose that you're going to be using, the l-carnosine? Adults, usual dose is between 500 to 1,500. You can increase even up to 2,000. As I said, in cognition, in schizophrenia or cognitive disorders, wherever you're giving it, you require up to 2,000 milligram per day. That's all been tried in many trials. For ASD, I think I would look at a dose of 800 milligram. The only limitation for l-carnosine, as I said earlier many times, it is rapidly degraded by carnosinase. And so it becomes variable bioavailability in different individuals, depending on what type of gene metabolism polymorphism we have. So before we routinely make it a prescription for several psychiatric conditions, I really call for large-scale studies and more robust evidence to come through. So I'll a little bit talk about the degradation. L-carnosine degradation is genetically variable. The more important one is the CNDP1 polymorphism. So those with high carnosinase activity will have lower benefit from the L-carnosine. So if you have somebody who's not responding very well, think about this as a reason. And it also explains why some people improve, why some people don't improve, why some people come up with a better metabolic response, better neuropsychiatric response, why some people not do it. So in those circumstances where it's not working well, you have a choice to work with anserin, which is not degraded by, this enzyme. What are the side effects? Relatively, I would say this is an innocuous drug. The only thing, Taru's study did not really pick out anything excepting one person complaining about gastric discomfort in the 150 people that they received. So most people will complain about nausea or an epigastric fullness or a loose stool. That's all you can have, and the dose are a little high. Very few people can complain about headache and dizziness. Mild transient fatigue can be experienced by some people. So even though there is no absolute contraindication for this particular disorder, but I think you can exercise caution, given that some of the metabolites can accumulate in severe renal diseases. And I think you should be a little careful in severe renal diseases, not in mild and moderate renal diseases. And particularly when you're going to give very high doses in seizure-prone individuals, that I think one should exercise caution. This is what I think. We do not have data relating to pregnancy. The safety data is not there for pregnancy. I would sincerely avoid its use in pregnancy routinely, unless in exceptional cases where the clinician is convinced that he should or he should give this. Otherwise, safety is not established for this. Just being a nutraceutical doesn't mean it's always safer. So that is a dictum we should have unless the evidence accumulates. So breastfeeding, again, we have a very limited data. We can't recommend. Yes, in children, it can be given. Many studies have been done on children with autism spectrum disorder. And I think we can use it in children. We can use it in older people because it's very useful for preserving cognition, making sure that the cognition doesn't deteriorate or even improving cognition, and at times fatigue. So it's useful in children as well as older people. How does it compare with other antioxidants? One of the common antioxidant is vitamin C and E, which most of us take on an everyday basis. Just compare this. I think when compared to vitamin C or E, the lipid peroxidation inhibition is very strong with this drug. The anti-glycation is very strong with this drug. The carbonyl scavenging is very strong with this drug. That is why it is going to offer much better metal chelation is going to be so much stronger. So this is going to give mitochondrial protection is going to be very strong. This is going to be a much better neuroprotection for the brain compared to vitamin C or E, right? So if you're going to use an antioxidant to protect your brain, I would choose l-carnosine rather than E. So how does it compare with NAC or omega-3 or l-carnosine? They have different roles. If you look at l-carnosine, I will think of neuroprotection as the most important thing and addressing cognition and perhaps negative symptoms provided you are using a 2-gram dose. If you're looking at omega-3 fatty acids, that's actually a good molecule for fatigue, particularly for disorders in which mitochondrial dysfunction is predominant, energy metabolism. That's why it's very helpful in fatigue. So NAC, we all know that it's a good adjunct therapy in people with obsessive compulsive disorder. I use it a lot in people with lived experience of addiction. And also it's useful as an adjunct in bipolar depression. So different agents have different roles, but I would say l-carnosine as for neuroprotection, cognition, negative symptoms, that's where it stands out. Okay, my final takeaway for the listeners is when you think about l-carnosine, think about it as a neurobiological buffer. A neurobiological buffer, which is an adjunctive multi-target protection. You are not going to treat it for symptoms. You are going to treat it for neuroprotection. And I think that the way of thinking about diagnosis should become different. You are offering neuroprotection to the brain that's been having so many pathophysiological mechanisms. This particular molecule as a supplement can address many pathophysiological mechanisms that are relevant in neuropsychiatry. So I would say l-carnosine is a molecule for dysregulated brain biology. Rather than specifically talking about disorders, I think you should start telling people l-carnosine is a molecule for dysregulated brain biology. There are several conditions that come under this purview and we can clinically use it. Thank you so much. And I want to really thank you. I know I've taken longer than what I wanted to do to deal with. Apologies for that. Srini, all to you.
It's exactly an hour's speech, but time stands still when you talk. Right? Unless otherwise you watch the clock, time stands still. Excellent overview on how it works, why it works, and where it works. The final point, as you said, it's brain dysregulation. And what you are doing is neuroprotection, multi-targeted. So wherever you think there is a brain dysregulation, like you highly pointed out, I have worked in like stroke, post-stroke rehabilitation. This works much better. Head injury, I have a very rich experience, and the neurosurgeon working with me is very, very happy with the results I have given post-head injury. Though traditionally we talk about starting neuroprotective drugs at a very early stage of head injury, but most of the time we do it even after 3 months to 6 months and still it works. And mostly I have worked with 400 mg, that's the max, and that dosage like 800, 1500 and 2000 may be impossible for any of our patients to use it because of the cost factor. Even at like 400 mg, it costs about 3,000 rupees per day, close plus minus. So it's unless otherwise it's sponsored and the company is willing to sponsor such studies where a higher dosage is useful, we won't be able to do it. But with 400 mg, literally it works much, much better in especially ASD. I was one of the earliest people to use and then find the results really excellent. And You have nailed it correctly. I'll leave it to the organizers. Is going to be any more discussion or any questions? How's it planned?
Sir, we would have certainly received some questions. Mr.
Yeah,
Umashankar,
there are some questions from doctor, sir.
Okay, somebody can read the questions and Suresh can answer. Somewhere I can
Yes,
fill
sir.
it.
Yes, sir. Generally, these adjunctive treatments are expensive and burden on the patient. Are the trials obtained through placebo controlled trial is good enough? The question from H. Chandrasekhar, Bangalore, Karnataka.
So, in my experience, I have found that I leave it to the patient. Like I view them very often and then I get a proper feedback. Even before the studies came in, I started using. I tell them this is the cost and see what's the result, and you think you can continue and it's producing result, we can continue. That's it. And many people, almost 80% of the people are willing to continue. Number one. Number two, in fact, once to make it anecdotal as well as the real liver experience case, the father was the one who used to accompany the patient and he said, I'm not seeing much of an improvement, and I stopped it. Within 15 days, the mother came with the patient and asked me, why did you stop it? I said, your husband only told me that he is not seeing any difference with the drug. Sir, he is not staying with him. I am the one who is staying with him. Only after starting this, he's been more quiet, more inquisitive, and he's asking a lot of doubts, questions. He has become more confident. It works. Like that, probably we don't have placebo-controlled studies to say that, but you can find it from your own experience whether this much is worth or not. Now I will request Suresh to fill in as well.
No, I think, like the question from Dr. Chandrasekhar is very relevant because, I think, you're not going to subscribe to something just by a placebo-controlled study alone, right? Really speaking, we require many more things to do. Unfortunately, if it was a pharmaceutical drug, a primary drug, this would have gone through rigorous trials, and then possibly by now you would have had so many systematic reviews and meta-analysis for each of the conditions. If you look at the literature, they are not available. I don't really think, not because the drug is useless. The first thing that we need to remember is this is not a primary drug for any condition. This is an adjunctive strategy. Adjunctive strategy as a molecule given with a multi-target protection and really doing some neuroprotective works through several mechanisms. So what you're really doing is to fill the gap with the primary drug is not addressing. So if you look at it that sense, you are not going to consider it like a typical primary drug for which you require all that Chandrasekhar sir is talking about. So I think we can proceed to other questions. That's a good question though. Yeah. We are not equating as a primary drug. I'm not trying to call it as a primary drug. Yeah.
Yes, sir. Already you have answered, sir. This is the initial time question. Is there any significant role of l-carnosine in cognitive impairment and dementia? Through your presentation, you have covered, sir. It is from Dr. Sumit Saha.
I can share the slide deck with anybody whoever wants it. The company can have the freedom to. It's on the public domain. You can share it with anybody who wants it.
Yeah. Thank you, sir. Thank you. And there is another question from Chennai, Dr. Divya. Hello, sir. Is there any evidence that adjunct therapy providing result to psychiatry patients?
Say it again.
Yeah. Hello, sir. Is there any evidence that adjunctive therapy providing result to psychiatric patients? This also you covered, sir. This is also asked in the beginning of the presentation. And there is an interesting question from Dr. Pankaj Singh from Varanasi, sir, Uttar Pradesh. What is common side effect of beta-alanine?
Beta-alanine is, I think I said there are two things, right? Beta-alanine and L-histidine. And beta-alanine, we all know that, this is one thing that could have some side effects, relatively speaking. The one that I noticed in the literature is the one that disturbs people is its action on the sensory neurons and producing the paresthesia. Paresthesia is the one which can produce. And of course, like any other drug, it can produce gastrointestinal side effects. And some of these drugs, they have a tendency to lower the blood pressure, lower the the blood glucose. It's one of the reasons why you should be very careful when you're combining it with, very aggressive treatments for hypertension and diabetes. When you add this, it has a tendency to lower. So I think the sensory side effects is the one thing that you should worry about in beta-alanine. Everything else is very similar to l-carnosine. So there was also interesting question on duration. Always, I think the question on duration is the most challenging question for any molecule, for any disorder. People come and ask me, how long should I take the medicine? When you say long, how long? And I think, sometimes people come and ask me, is it lifetime? Whose lifetime are you talking about? If it is my lifetime, it's going to be shorter. If it is going to be your lifetime, it's going to be longer. So it's a choice. So I just jokingly say this. But I think for these drugs, I don't know the answer. We don't know how long to give it. But I can tell you something. Why should not give beyond a particular? If you don't see any improvement with l-carnosine for any particular condition that you give beyond 8 weeks, and I think if you don't see any improvement, this is time that you need to look at and say he's not responding, maybe because he's a degrader of this particular drug. Maybe it's not working with him or any other reason. Stop it. You don't have to continue and persist with that and waste his money or her money, right? So 8 weeks is a critical point. Otherwise, I think it's up to the person. See, when they show showing improvement, particularly I think children with autism spectrum disorder, when they start to show improvement, and I think when parents want it, it is up to them. It's a dialogue between the therapist and the patient and the caregiver. It's a conjoint decision we make and say, if you find it is useful at this point in time as an adjunctive therapy, you continue as long as you can afford it. Because we don't really see, we don't have the data related to what is the long-term, data of this. We know that in short term, it doesn't produce much problem. Intuitively, it may not, because after all, it's a nutraceutical. It may not. But I think we require data. I would urge the company, now that you're marketing it so aggressively, maybe conduct something like a post-marketing surveillance. Look at what the data that's coming up. Ask the physicians to report on what happens, how long they give. Such a vital information will be informing all of us, because many of us are sitting at our own clinics and giving it to our own patients. And I think we are happy, like Srinivasan says, I'm happy with this and I'm providing it. And then he influences some people and then we start writing. So, but I think there should be also an organized way of collecting this data and inferring from the data.
Sir, there is one more interesting question. Is there an emerging evidence that l-carnosine can support synaptic plasticity or neurogenesis? And how relevant is this for cognitive enhancement in psychiatric practice?
See, if you look at the mechanism by which synaptic plasticity could happen, look at the neurogenesis part of it. The mechanisms through which synaptic plasticity. I did show a slide in which I talked about how these multiple mechanisms, oxidative stress, inflammation, myocardial dysfunction, all that are going to lead and work at the network level, which means synapses and networks, and improve their function, network function and synaptic function, lead to synaptic plasticity. And we know that l-carnosine is capable of inducing synaptic plasticity. What are the reasons why we consider this drug addressing the core mechanisms of pathophysiology behind brain disorders? So the answer is very much an yes.
Sir, one more interesting question, sir. In your clinical experience, which subset of psychiatric patients shows the most meaningful response to l-carnosine supplementation?
I think the whole literature is voting for autism spectrum disorder as a most important diagnosis. In my clinical experience, I'm using it because I don't see so many children with autism spectrum disorder, because I'm not a person specializes in child psychiatry. I see very little people, but I think I see a large number of people with lived experience of schizophrenia who present with cognitive dysfunction. That is a population for which I'm using l-carnosine abundantly, liberally, right? This is one population I can say. Like I use NAC very much for people with addiction. I use addiction, OCD, NS is my, nutraceutical. Whereas when it comes to schizophrenia, I also don't see so many people with Alzheimer's, for example, but there are older people who come to us. And I think when you treat some of the people with dementia, we combine it with already existing drugs like dorapicin and memantine, it's pretty useful. And Srini was sharing with me a lot of cases in which, number of people that, Srini, you have the wide experience of this particular.
Yeah, as you said, ASD, one of the things, though you talked about literacy in a normal children, you did not touch upon SLD, learning disability as such. In learning disability also, it works, as you rightly pointed out, ADHD it has not helped much. In fact, most of the studies you said validated what my practice is doing, right? Alzheimer's says it really works with existing drugs. When you add this, the results are phenomenal. Very resistant OCD sometimes I use it. Depression, I have not used it as of now because for a very long time we have been talking about depression as an inflammatory disease and testing the HSCRP, which is higher, which we have done, and it has not helped much. So schizophrenia has, though we talk about NMDA receptors and all that, memantine as such has not helped much, whereas in such cases, l-carnosine has helped. But like the kind of schizophrenics I see are completely different. I catch them very early and I use a very low dose. So I come across much less number of schizophrenics who are having cognitive dysfunction in limited cases. Yes. And the largest number I have used is in post TBI, cognitive impairment, where it produces wonderful results. Because I work in a multi-specialty hospital, because I could say that the number is huge with post TBI cognitive dysfunction as well as post-stroke dysfunction, where some of the individuals have recovered speech when you combine with memantine and l-carnosine.
Sir, this question is for Dr. Srinivasan, sir.
Yeah.
Given l-carnosine's role in regulating glutamate toxicity, can it complement anticonvulsants or mood stabilizers without pharmacological interactions?
Yes, in fact, Suresh talked about using it in bipolar disorder as well as people with seizure disorder, to use it as an adjuvant. Yes, it can complement and probably reduce the toxicity as well. Because over a period of time, we are coming across cases where sodium valproate is inducing extrapyramidal side effects in some of the individuals. So probably preventing some of the side effects as well with sodium valproate especially, this may be helpful.
Thank you, sir. Thank you.
I will say is more than 100 companies having come in, the copyright issues, all that has gone up. The price has to come down if you really want it to help the patients. Like the dosage Suresh is talking about 500,000, 1,500 mg. If you really want people to use, then people cannot afford at this present cost. Something has to be done about it. That's my humble request during this session.
Thank you, sir. One more question from
We can't hear. Rajamanikam, you're mute. You need to unmute. We didn't hear the question at all.
Sorry, sir. Sorry. I'm just reading, sir. There is a question from Dr. Tejasvi from Dharwad, sir, Karnataka. Sir, please, could you enlighten us on any systematic review, meta-analysis available regarding l-carnosine in ASD, dementia, and cognitive syndrome in schizophrenia?
That's what I'm saying. I was not able to figure out. The only meta-analysis I found was for depressive disorder. That's what I quoted in in my presentation. Because I think this particular drug being what it is as an adjunct, you don't really come across this. That one was also, studied in detail, mainly because I think people wanted to look at the quality of life. And I think, just for depressive scores, you wouldn't have looked at. Quality of life is something that people don't address with typically at antidepressants. That's one of the reasons why this meta-analysis was conducted. There are specific reasons I think we should. If you look at the number of studies that are available, you do a PubMed search, you don't get, there are so many. See, I think where there is so much of a literature, is on cell studies, on animal studies. We can't ignore the value of all those. Those cell studies and animal studies helped us to build a model for our observational studies in human beings. And they all have begun very late. They're just about decade old, right? So we need more time to come at, would you be having a systematic review of lumateperone, for example? Like recent drugs usually don't have. So you would take some time, particularly, because it's useful in so many conditions, several neuropsychiatrics across. I think the diagnosis doesn't matter here. That is what I'm repeatedly wanting to tell. People don't want to think in terms of diagnosis. Think in terms of what pathophysiological mechanism you are seeing in this individual, where this molecule could actually fit in, given that it is an antioxidant, anti-glycation, anti-lipid peroxidation, mitochondrial dysfunction, inflammation. If you look at those pathophysiology as a key way of thinking, then your way of thinking will become very different. Otherwise, you'll get bogged down to diagnosis, where I think we'll just lose this bus.
Thank you, sir. Sir, there is one more question from Dr. Amuda Rajeshwari from Madurai. Sir, how long in ASD we have to give this drug?
I did answer that. I think
already you have told.
As long as the people believe that ADHD, first of all, we don't have evidence to say that it is
ASD, sir. Autism.
ASD, I think I told the answer already, because I think
Yes,
depending on the caregiver, if they can afford it. See, you take the example of diabetes, for example. Forget all psychiatry. Diabetologists prescribe l-carnosine because actually it's a very good drug, because the metabolic processes are improved because it's abundantly found in the muscle. No, actually this is a drug which is used for exercise enhancing, right? That's how people started using l-carnosine. L-carnosine was used by people who are exercising, want to improve, want to preserve their muscles. That's when it was introduced to begin with. Much before we all know that it's a neuroprotective drug, right? Because it's abundantly present in the skeletal muscle. So similarly, I think diabetologists started looking at it because of its cardiac production. It is also found in the heart muscles, because it's also the glycation effect is the one that you see in the HbA1c that you study. Is an amoric product, right? Is an intermediate product, because it's a process of glycation. You can reverse it, right? So diabetologists give for 6 months minimum, and then reassess with the patient. They go back and ask him, did you do well with this drug? Are you okay with this drug? I know many other diabetologists who have prescribed for longer periods of time, but because the client came and said it has got a protective effect on them, they are looking at diabetes related consequences being avoided because of this advanced glycogen end products, right? They are toxic to many, many organs, right? So that's what they're looking at as an end outcome. So they actually give for minimum of 6 months. 3 to 6 months is where minimum they're right. They don't even think about anything less than that. After that, they reassess with the patient. This is what many people who practice diabetology do it, right? So we need to learn lessons from them. How that they're able to do it, right? So we need to assess and then go back and ask them. I think it's a dialogue between the patient, caregiver, and here. People will take a product, buy a product, if it is efficacious and useful to them, with absolute tolerability. And particularly when they learn it is not a pharma drug, but is a nutraceutical, they become more convinced about it. Because we're living in a world, supplements are more accepted than primary drugs. Your whole social media is full of them, but that's where the problem comes. That's where some of us become very, very, skeptical. Beyond skepticism, we should say, I don't want to believe everything that people say, but I want to do my own work and research and read about it and learn the pathophysiological mechanisms and science, see whether it makes sense, make this plausible for me. As a scientist, you think, is it plausible? Is it perhaps, what I'm doing? Is it can work? Like Srini has been giving intuitively. He's a very genius of a guy. He picks up things even before understands the mechanism. He knows it's going to work. Invariably, he'll prove to be right? Because, it's experience, years of experience, he's working on it. I work the reverse way. I ask a question, where is the pathophysiology, where it could be? It could be a combination of both. Wisdom like Srini, or reading and evidence collecting like me. The combination like this would be useful.
In fact, as the question, Suresh, I don't remember the name of the author who said, even in schizophrenia, you have to do what's called motivational interviewing, like in alcohol. You just went to stop drug, you try to make him continue as long as he can. Because I have seen people maintaining well for 6 years, 7 years with about olanzapine 2.5, and then suddenly one day you stop it because they are in remission for 6 years and they relapse and the excitement is very severe. Like that.
Interestingly, the study on ASD, the RCT, not only looked at the reduction of hyperactivity, looked at compliance with treatment. I thought it is a fantastic way of looking at an outcome in a chronic disorder because most people don't comply with the treatment, right? That's why the treatments fail. So the question that they asked was, adding this adjunct did help in compliance with treatment. So interestingly, they found increased compliance when they took l-carnosine, right, along with risperidone. They're only taking risperidone. It's advantage, right? Risperidone obviously reduces hyperactivity and it makes drug not to increase the dose. At the same time, able to make the children to comply with the medication.
Not only comply with the treatment, comply with the therapy part also.
Yes. As you said, psychological intervention.
Their
They participate
cooperation
better,
and learning
engage
from the
better.
therapy was much better with l-carnosine.
So,
I think it's time, like 10 o'clock.
So thank you all doctors. I'm Ashish Dudmande. I would like to convey our vote of thanks. Thank you the faculty, Dr. Suresh Kumar sir, for taking this session, and Dr. Srinivasan sir for being the chairperson. And both of you have, sir, given us so much of new avenues of thinking about l-carnosine as a therapy in itself. The topic for tonight was adjunctive strategy in psychiatry, exploring the role of l-carnosine, which has been totally backed with such a long list of evidences that both of our eminent faculty has given us today. Thank you so much for sharing, sir, your experiences in this evening. I would also like to thank all the attendees, all the delegates who have been part of this knowledge exchange program. As a part of Linux Laboratories, we would definitely like to continue this kind of endeavors of scientific dissemination to all the specialists of neuro and psychiatry. And we look forward, sir, for all your participation and guidance to take our l-carnosine brand, our Ignicar, to further strengthen as the pioneer and leader brand in the market. Thank you so much, sir. Have a great evening, and it has been a wonderful 1.5 hours of knowledge exchange with all the specialists. Thank you so much. Looking forward for next meeting shortly. Thank you, sir. Thank you. Have a nice day.
Thank you, Srini. Thank you.